Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. Here we are in the Nutmeg studios in Farmington, Connecticut. I am your host, Kurt Barwis. I am really excited to be here today with Dr. Olszewski. Dr. Olszewski is a surgeon at Bristol Health. Dr. Olszewski, welcome. Tell us a little bit about yourself.
Yeah, hi. I'm really excited to be here. So thank you for having me. I actually grew up in Colorado and went to Colorado State University. I was a science major, but I was focused more in the lab side of things, but transitioned wanting to go into the healthcare side of things. So I moved to Philly and went to Drexel for a master's. And that put my foot in the door so that I could go to medical school. And I also went to Drexel for medical school. And I loved the area. I ended up staying and going to a kind of a small community hospital outside of Philly called Abington, and did my surgical residency in Abington. I fell in love with the idea of the foregut, kind of doing stuff on the stomach and the esophagus. So I did go to Pittsburgh for a one-year fellowship in foregut. And then I was lucky enough to find my way up to Connecticut and to Bristol. And so now I'm a general surgeon working at Bristol.
So I think we were the lucky ones to have you join our team. Nice. And as you're talking about your past, Abington Hospital, literally I went to middle school, like just miles from there in Meadowbrook. And so that's where I grew up, in that area. And I actually did the audit of Abington Hospital when I worked in public accounting. So
that's too funny.
You're making me, I remember seeing this little room towards the front entrance and stuff like that. And it's really a cool place. But your career path is just quite extraordinary. So you've really, you kind of followed your heart, it sounds like. Your passion and for what you wanted to do. Yeah. You didn't really see yourself being a foregut surgeon, a general surgeon when you started.
No, definitely not.
It kind of just happened because you got drawn into it.
Exactly. Yeah. That's a good way to put it.
And it's a long journey, so it's not like it happens overnight. So
no, it does not.
So I think one of the things people kind of get curious about is like, how do you end up? Because Colorado, Philly, here. I mean, it's and you talk to a lot of physicians, a lot of surgeons, and relocating is all part of it. And so what made you pick Bristol?
Yeah. So after being in Colorado, people are very outdoorsy there. So everything is, you want to hang out with somebody, it's let's go on this hike, let's go camping, whatever. Yeah. Very outdoorsy. And then I went to Pennsylvania, where you can still find little kind of nooks of people that do that sort of thing, but mostly it's let's go to this bar, let's go to this restaurant, right? And
no, there's no bars involved, I'm sure.
The food is amazing, so don't get me wrong. But I kind of fell in love with the East Coast while I was in Philly, but I still wanted to get somewhere that had that outdoor touch, and because I still missed that with my roots in Colorado. And so I ended up getting the interview up here at Bristol, and I mean, Connecticut is really beautiful. I think people that are from Connecticut don't realize they don't have that same appreciation for it, I think, that I do.
So was it like the first time you came to Connecticut, or had you been here before?
I had been passing through, but I never had stayed actually in Connecticut. Yeah. So it's just, I think it's really beautiful, and it does have that access to outdoor stuff. Almost everybody that you meet that's from here has a favorite hiking trail, which
Oh,
like
for
that
sure.
did it for me. A lot of people I met while interviewing were like, oh, you got to try this, you got to go here, you got to do this.
Yeah.
And there's access to everything. So all of that really helped kind of make me go full circle where I still had the food and the East Coast vibe, but with a little bit more of the outdoorsy action.
Yeah, I think you just kind of summed it up so well. I just remember as a kid coming up here to visit relatives at like the age of 8 and 9 and just sitting on a couch for a weekend and thinking, I'm never coming to Connecticut. This is like the most boring state in the whole entire country. And here I've been 18 years and
Yeah.
exactly for the same reasons that you just laid out. It just, it's a beautiful state and there's great diversity in everything. They've really protected the environment very well and the nice natural areas and all the bike trails, hiking trails are just extraordinary.
Yeah.
So talk to me a little bit about your practice. So what do
Yeah.
you like to do as a
Yeah.
general surgeon?
So general surgery is really neat in that you kind of can get your foot into any avenue. But at the end of the day, you're trying to take a diagnosis and see, like, can I make this patient better in the long run? And so you can do all the main things you think about: gallbladders, hernias, appendix, colon, all that kind of general stuff. And then there's other little avenues that you can take. So, you could do all the little lumps and bumps. So if somebody says, hey, I have this weird nodule, can you take that out? And that's something very satisfying. You can take it out and take care of the patient. So there's a lot of variety and a lot of different kind of things that you can do. And I like a lot of it. I like all the main general stuff. And as I talked, I did the foregut fellowship as well. So what that means is that's basically the first half of the gut, and it's involving the esophagus and the stomach. So patients that have really bad acid reflux may because their stomach has went up into their chest. And so you actually need to surgically bring it back down and tighten up the diaphragm in order to keep that reflux from happening lifelong. And it can save the patients from getting diseases in the esophagus, and it can save them from a lot of discomfort that they've been having and get them off medications in the long run. So that's my favorite.
So wait,
But-
so I never really kind of understood it that way. So
Yeah.
So what kind of symptoms would somebody have? I mean, that's the thing I
Yeah.
always think about is like I hear people like they had pain for like 2-3 years and then they went and finally had their gallbladder out and it's all better now.
Yeah.
Right? I just had somebody tell me that. It was
Yep.
like they couldn't figure out what was wrong with her for how many years and then I can't remember whether you did that or somebody else
Yeah.
did it, but the patient was so excited and happy that they had it done. So this other issue you were talking about where the stomach kind of goes up into the esophagus,
Yeah.
like, is it just reflux? Is it
All over the map. So most patients, about 75% of patients present with heartburn or reflux. So they've got the burning sensation in their chest or they've got fluid going into the back of their mouth, particularly if they're sleeping or laying flat. That's about the majority of patients present that way. There's a subset of 20 to 25% of people who present with LPR, laryngeal pharyngeal reflux. Don't need to know
well,
that
that's
word.
a whole
The whole-
dictionary full.
It's like saying GERD, it's
Yeah.
like LPR. And that's actually a lot of airway type symptoms. And those patients frequently go misdiagnosed because they have recurrent asthma bouts, they have sinusitis, they have postnasal drip. And all of that is the acid coming up and kind of mucking with everything in the back of the throat or the airway instead of the esophagus. So the esophagus symptoms are the ones with the heartburn and the reflux. But if that fluid gets up and it gets into the back of the throat, the back of the nose, it can start to cause those other symptoms. So frequently they've seen their pulmonologist and their ENT and their primary, and nobody can figure out what's going on.
I know somebody that fits exactly that description, and
Yeah.
now I'm going to go talk to them because
Yeah.
exactly what I would have never connected those two things together.
Yeah, so a lot of those patients too don't have a true hernia at that spot. So the hernia is where the diaphragm should be a little small hole that the esophagus comes through. But if it's stretched bigger, then the stomach can come up into the chest through the diaphragm. So that's when surgery is beneficial. Sometimes those patients, they just have a poor valve. And so they can actually go on medications that can help their symptoms. And then if they decide that they want the surgery anyway, a lot of times we can justify it based on their symptoms, and we can still I can still tighten up that valve.
Wow.
Yeah.
So like, you know, it's interesting how you kind of laid it out, and again, I hear so much from people, like they've gone through years and years of different treatments and different specialists. So how does somebody kind of just go all of a sudden, you know what, I'm going to go get you a surgical consult with Dr. Olszewski?
Yeah.
Or is there something, should people be thinking about that because they've gone through like years of trying, you know, struggling with, you know, some kind of pain, and nobody suggested or looked at their gallbladder?
Right.
I mean, like, how does a person
Get
kind
to
of
that
navigate
point.
to the right place?
Yeah, it's really tough because there's a lot of different symptoms that can go toward a lot of different problems. So gallbladder is a great example. The classic example is you eat a fatty meal and you have right upper quadrant pain. Many patients do not present that way. They get pain right in the middle, or they get nausea after they eat. And just like you said earlier, it's not until after they have their gallbladder removed that they say, hey, all of a sudden all these symptoms went away that I was having. So it's really common, and that's the same with the hiatal hernia and all the stuff I'm talking about with the stomach, is everybody's symptoms are a little bit varied. And so it's really hard to have an algorithm that's like, if this, then that. And so it really takes having a really good primary who's listening to the concerns and getting you referred to the right place. The nice thing about the way that we function is it's very easy to get into our office and see us. And so if there's a patient that thinks they have these symptoms, I'll see them without their primary sending them. And I'll go through the whole thing, go through all the different symptoms they're having. Actually, I have a whole like checklist I make them go through. And then we start the workup, and then we can find out what's really going on.
That's really, really important advice to the viewing audience, because like I said, I hear a lot. I've lived here for a while, so people ask me all kinds of questions. Now that you've kind of laid it out for me, I'm going to go. I know one person I'm going back to say, you ought to have this consult done. So then the hernia side of it, you know, you hear, you know, people walk around with hernias for a long time. Maybe they don't even get them checked out. They just figure, I can just live with this.
Yeah.
But there's danger from doing that, right?
Yeah.
I mean, so talk a little bit about that. Like,
so hernia is broad. There's a ton of different areas you can have hernias. So earlier I was talking about a hernia. You cannot feel the hernia I was talking about through the diaphragm, because it's in between, it's in the middle of your chest. So it's in the middle of your rib cage. So that kind of hernia you can't feel. That's separate. But the general hernias that patients do feel and either ignore or don't think are a big deal are either in their abdominal wall, maybe around their belly button, or down in their groins.
yeah.
So those hernias, if they're small and they can go in and out, then they're typically not an emergency or an urgency at all. We don't necessarily have to operate on those patients unless they start having pain or symptoms from the hernia. When it becomes an issue is it's typically a very small hole, and the bowel can actually slip through the hole. And what'll happen is more and more will get pushed out until it's mushroomed out. And now you can't push it back in. And once you get to that point, there's always a risk it could get kinked off inside the hernia. And when the bowel gets kinked off, it starts to lose blood supply. Now we've gone from an elective, possibly urgent situation to an emergency situation. And so that's why we repair them while they're small, why they don't have bowel stuck in them, because it's much safer to do that. And then you can pick the day you want surgery. You can go home the same day. Just decreases the risks altogether of getting to that emergency situation.
Yeah, I remember I had 2 hernia repairs, and the first one I didn't know because I was born with one. And then the second one, and it really wasn't all that bad, but when I would do something physical, like I would lift things and move things, then it got extraordinary painful, and I finally broke down and had that taken care of. And I was glad I did, because I think you just kind of convince yourself, oh, it's no big deal, you're going to be okay.
Yeah.
And then it, you know, I finally did it, and I was like, wow, what a difference this makes. I mean, and I think that's part of the problem is people get used to whatever you're living with, and you go through it. So you also talked about small lesions and things like that. And a lot of those things could actually be potentially cancerous, right? I mean, so whenever you take something off somebody, it goes through a full process of goes to the pathology lab, and we look through it and that stuff. Any thoughts about that? I mean, because people all the time, well, I got this thing glowing over here. What is it?
Yeah. Yeah, so a lot of those patients that have a really high risk of anything on their skin could come in, do a little skin exam. Anything that looks concerning, we can take off right there in the office. So we just actually numb up the area and take it and put some sutures there, send it to the pathologist, like you said, and then we know what it is and can make sure it's nothing dangerous. It's very, very important to get those skin checks. If you're just getting a routine skin check, those patients should be seeing their dermatologist once a year, especially the high-risk ones. But if there's any kind of thing that's a lesion that needs to be surgically removed, the dermatologist sends them all to us anyway to get removed. So we see a lot of those. I would say of the general surgeons in the office, we're probably taking 3 to 4 things off a day in the office, just because it's very, very common for patients to have something. And then it's very uncommon for it to be cancer. But with squamous cell and basal cell cancers, which are the ones that we see most often, patients that have been in the sun their whole life, things like that, they can be curable with us just taking off that lesion and make sure it doesn't spread.
So my next door neighbor is Dr. Jerzik, so he's a dermatologist, right? So, a lot of times they'll just come over and, no, you need to go have this taken off. And then I've been to Dr. Toto and before that, Armin Ciccarelli. So everything you just described, I've been through, and I think it's very important. People just don't realize they have something growing, they should have it checked out. And then also the exams. I mean, I know both dermatologists in the city do that, and they have PAs that do it. So, I get people asking all the time, like, well, he's a guy and they're going to check my entire body out, but there's a female PA there, and there's a, so that you don't have to worry about that stuff. So it is absolutely important, because I think, that particular cancer can be very bad, really bad. Yeah. So what else? I understand we have a new surgeon that's joining us.
Yeah.
Talk a little bit about that, because we've not had a colorectal surgeon.
I'm so excited. So Dr. Mann is starting in September, and he is doing his colorectal fellowship. So what's really neat about that is that we're going to be able to add somebody who's going to do general surgery with us. So he's going to do the gallbladders and the hernias and all that. But he's got advanced modalities for taking care of the colon cancers, which all of us do. We all take care of colon cancer, but he's going to be able to do it with the robot, which is super exciting. And then also all of the rectal cancer patients. Historically, it's just a tough area to operate in. And so we send them to another hospital. And what we'd really like to do is keep those patients close to home, keep them close to their oncologist, and be able to take the best care of them. And so we're going to be able to do that for those patients now, which is so exciting. And then he's also going to be able to do all of the little stuff. So the patients who have bad hemorrhoids or bad disease in that area, he's going to be a pro at that, which I think will be a really, really excellent addition to the team. And lastly, he's going to be able to do screening colonoscopies. So, the new data is showing that we want everybody at 45 years old now to come in for their first screening colonoscopy. If they have a family member with a history of colon cancer, we actually say 10 years before that person had colon cancer. So we have this, every single patient that's above 45 should be getting these screens, because if you can catch the cancer before it can spread, it can be totally curable. Yeah. And so now we have an additional person coming in who's going to be able to just get all of these patients taken care of and screened, and, potentially save a lot of lives in the long run.
You just said something that I have not heard before. You said if you have a family history of a cancer, colon cancer.
Of colon specifically.
Colon specific. Yeah. The first colonoscopy should be 10 years before that person.
Before their diagnosis, correct. So if your
didn't know that.
Yeah, if your dad had it at 65, you're at 45. If he had it at 55, you're now at 30. You're going to, sorry, I did that math wrong. You're doing it 10 years earlier than that, to make sure that, because colon cancer can be familial. So we do those screens more frequently as well. So you get it 10 years before the family member's diagnosis, and then you get it every 5 years if yours are negative.
Wow.
Yeah.
That is such a simple way to think about it. And people ask that question all the time, like, oh, I have a family history, But I know I'm not supposed to have it until this time. But what you just said was 10 years before their
10
initial
years
diagnosis.
before, and then every 5.
That's really important advice for people to understand. So,
Yeah.
but now do you also do breast, or do you?
I do not.
Do not do breast. So some of the general surgeons do breast. So I was just curious about that.
Yeah, Dr. McAllister does some of the breast stuff. We just added Dr. Boschman. I think she was on the show recently.
She was amazing.
She's excellent. We love her. But I know that Dr. McAllister still does some of the breast surgery as well. That's, as I was saying at the beginning, everybody does a little bit of different stuff. So we all have our little things. So Dr. McAllister does thyroids and parathyroids. Dr. Marshall, Dr. Bagdasarian both do pacemakers, which is very uncommon for general surgeons. So that's pretty cool. Dr. Bagdasarian does some vascular. Dr. Marshall does tracheostomies. So we all kind of have little niche areas that we...
And Dr. Marshall, wasn't he a trauma surgeon?
He was, yeah. So he can do some pretty cool stuff.
He did. I think he did a pretty cool thing the other day. I heard about a save that he had that was an emergency that was quite extraordinary.
Yeah, just super sick patient in the ER that needed something done immediately, if they were at a trauma center, and he took care of it.
Yeah, I don't think people realize that even though we're so close, there are clearly still things that can happen to somebody that it doesn't matter. You can't transport. It has to be done right now. And having a trauma surgeon like that really was an incredible outcome for that patient.
Yeah, it would have been really tough for that patient to have made it to another hospital in time based on everything that was going on.
So you really cover a wide gamut. You mentioned robotic surgery, but you do laparoscopic surgery.
Both. I do both.
You do both.
Yes.
Okay.
Yes.
And so people, I think, they hear robotic and laparoscopic. So maybe just spend a minute on
of course.
Like how you make that decision about what you're going to do.
Yeah. So it's very case-based and very patient-based, depending what you're doing. The laparoscopic is tiny incisions. The robot is a little bit bigger incisions, but what happens is the tube that goes to the abdominal wall, the torque is now in the robot instead of at the abdominal wall. And so if you're doing a really complex case or if you're doing a heavier patient, the robot is key. So I love doing laparoscopic gallbladders. I think there's no reason to get the robot involved. But if you have a heavier patient and you need to get to their gallbladder, the robot is a really, really excellent resource. And the robot doesn't do anything. It's just a device, basically. So there's no AI. There's nothing weird like that.
It's like a video game you're kind of
It is kind of like
there.
a video game.
I can't imagine laparoscopic surgery because you're working in reverse.
No.
Well, I mean, if you go this way, it goes this way. If you go this way, I mean, I don't know if I could. Anyway, but I know that's why it's good that you do it. I couldn't do
pretty quickly.
So this has been great. Any thoughts for the viewing audience as we kind of bring this to a close?
I think the biggest thing, especially at Bristol, is that we are immediately available. So if you have a patient who has something going on and their primary is months out sometimes, call the general surgery office and get a visit with us because we are also capable of working it up and figuring out what's going on. If it's something surgical, we'll take care of it.
Dr. Olszewski, this has been absolutely an education for me. I really appreciate you being here. Thank you so much. This is Bristol Health Cares, and if you have any suggestions or guests you'd like me to bring on the show, you can email us at cares@bristolhospital.org. Again, that's cares@bristolhospital.org, and I will do my best to try to get them on the program. A special thank you to Nutmeg TV. This is a nonprofit, community-based organization that needs your help at all times. Without them, these shows, many shows that they carry wouldn't be possible. You can get a subscription, and by the way, it's a really cool subscription because it's free. They have really advanced capability in the studio, all new digital high definition cameras, and a phenomenal production crew, which I thank so much for what they do for this show and for me and for the community as well. So until the next time, thank you very much. Stay healthy, and I'll see you at a future episode.